This morning we have Dr. Alex Nantsios. He's one of our cardiac surgery residents. So we're happy to welcome him here this morning. He's going to be speaking about ischemic MR. So welcome, Nick. We look forward to your presentation this morning.
Thank you very much, Dr. Stanek, for the opportunity to have the podium to speak today. My topic today is ischemic mitral regurgitation, a dynamic entity with an evolving therapy. And as we know, it is a therapy that has evolved through the years to initially treated surgically, and now to pretty much managed by every member of the heart team. So why is ischemic MR important? Well, as we see from this trial from the late 90s in patients post-MI, it carries a poor prognosis. Even the presence of mild degree of MR was associated with independently higher mortality and worse outcomes post-MI. The 5-year mortality in this study was measured up to 40% 5 years post a myocardial infarction. Ischemic MR is complex, and as most patients had multivessel disease benefiting from CABG early on, it became a condition that surgeons became familiar with, and we came to realize that it was one that was complex. As you see here in this series, that even the presence of 2+ MR at the time of CABG increased surgical risk from the standard risk, which was 1%, really for a low-risk patient. The presence of 2+ MR increased the risk to 3 to 4% in this study, even performing just CABG alone. Now, it's also well known that the effect of a combined operation is to increase and add morbidity to the procedure. So adding a mitral valve intervention further increased this risk to what sometimes is measured up to 10 or 11% for a combined CABG MVR. These patients, secondly, are comorbid. This is an early series from the Cleveland Clinic. It was quite clear that patients with ischemic MR had worse outcomes when compared to other etiologies of MR, like degenerative disease. And this was alone in this study attributed to the burden of comorbidities and LV remodeling. When we look at the patients treated at our own institution for ischemic MR at the time of CABG, we see really the same pattern. Predominantly, patients have triple vessel disease, prior infarction in 3/4 of patients. A third of patients were diabetic, they were vasculopaths. 50% of them had moderate degree of renal dysfunction, and their mean LVEF was 38%. And this gave them, on average, a predicted surgical mortality, Euroscore mortality of 6%. So it was clear that these were higher risk patients. Now, the third reason that makes ischemic MR complicated to treat, at least with intervention, is the mechanism. So the mechanism of ischemic MR really comes down to tethering. What do I mean by tethering? After an infarct, with ventricular remodeling, the papillary muscles will start to be displaced outwards. And this creates tethering forces through the cords on the mitral valve leaflet and makes MR more likely to occur. Secondly, as MR will occur and left atrial pressures will begin to be increased, you get left atrial dilatation, and in some patients, atrial fibrillation. And this will start to lead to dilation of the mitral valve annulus, which is really the second mechanism of ischemic MR, what we call Carpentier type 1 etiology. And tethering is what we call type 3B etiology. And together, these can contribute in varying amounts to ischemic MR. And then finally, ischemic MR is heterogeneous. It's not really one entity. Although we like to group it into one condition for the ease of studying it, it's really not just one condition. Just as in this Greek salad, it can vary in a variety of different factors in terms of magnitudes. Coronary status, whether or not they're revascularized, the viability of the myocardium versus the amount of scar, the degree of LV remodeling within a certain patient, And then the mechanism of MR, whether it comes down to predominantly tethering at the posterior mitral leaflet versus tethering, balanced tethering globally, is the mitral valve annulus dilated. You can see here, these two different patients both have MR on the functional basis. However, likely, as you could imagine, patients, in these two groups would likely be treatment targets for different things. Patient here on the right with more ventricular dilatation, a lower EF, predominantly scar, prior CABG, and nothing to be revascularized is different than the patient with, isolated RCA ischemia and inferior wall hypokinesis, with less remodeling, less tethering, and potentially a dilated mitral valve annulus. We would think and strategize differently our treatment management for these patients. So let's just quickly look at a case. 56-year-old diabetic gentleman with multivessel coronary disease. He has a CTO of the right coronary artery. EF is 36%, and his LV diameter diastole is 5.9 centimeters. He has 3+ MR. He is on somewhat of a medical therapy that may not be quite optimal, and his ECG shows a wide left bundle. What's the next best step in the management for this patient? Should he be referred for revascularization with PCI? Should he be sent to surgery for combined CABG MVR? Should he go to advanced heart failure for further optimization of his medications? Or should he go to EP for a device? Really, I think it can be kind of complex when you look at a bird's eye view to really know what the next step is. But I think with my talk, I hope to walk through the evidence and the evolution of the evidence over the years of this condition. So ischemic MR was initially a surgical disease, and replacement was the first intervention that was applied to these patients with moderate to severe MR. And it was usually with a tissue valve, given the poor prognosis and life expectancy that were associated with these patients. Now, two factors made surgeons, want to migrate towards a repair in this condition. And first one was really the theoretical effect of deterioration of the LV with disruption of the subvalvular apparatus. And the second reason stronger reason was the association of valvular-related clinical events that clinically made a replacement less desirable in these sick patients. As you see here from our outcomes, replacement is associated with valve-related events which increase the morbidity, bleeding, stroke, endocarditis, reoperation are all things that you have to consider when patients receive valve prosthesis. So many groups initially advocated in the early 2000s for repair using what was called an undersized ring annuloplasty. And this was essentially a ring that cinches down the annulus and making the diameter smaller in order to improve the coaptation of the two leaflets. And various observational data initially suggested that undersized annuloplasty in combination with CABG was successful in reducing the MR and suggested to improve symptoms and potentially start to reverse remodel the RV. And as you can see here, predominantly it had an effect in patients that didn't have significant LV remodeling. In those that had LVs that were more than 65 millimeters, they had poor survival no matter whether or not they had the repair or not. This is two RCTs, early RCTs that showed mitral valve repair with the undersized annuloplasty plus CABG improved functional capacity at 1 year, as well as had suggested to have LV reverse remodeling in these patients when an annuloplasty was added in addition to a CABG. So when these patients were followed to long-term follow-up, there was a clear signal for mitral regurgitation recurrence with annuloplasty alone. So in the long term, we've questioned this technique as really a cure for heart failure and ischemic MR. Given the uncertain increased benefits and the significant additional risk of a combined procedure in these patients, we asked ourselves, can revascularization alone improve ischemic MR? On one hand, CABG, as we know, may help with LV function improvement and remodeling. On the other hand, does leaving a leaky valve in terms of the MR cause potentially heart failure adverse associated events down the road, necessitating additional mitral valve intervention? The benefits of surgical revascularization in ischemic cardiomyopathy are well demonstrated, as we know, in the STITCH trial. This is the 10-year follow-up. We see that CABG has a mortality benefit when compared to medical therapy alone in these patients with ischemic heart failure. In this subgroup analysis of patients that had significant ischemic MR from the STITCH trial, those that had CABG alone actually had reversal of this effect, reversal of the curves, where they actually had worse outcomes initially compared to medical therapy. And in order to maintain the survival benefit with revascularization, these patients needed to have an additional mitral valve intervention. When examining the natural history of ischemic MR with revascularization, uncorrected at the time of surgery, it was quite evident that moderate MR doesn't reliably correct with revasc alone. And actually, in up to 50% of cases, it would either worsen or persist. So how do we predict who improves with revascularization alone? This brings us to the importance of viability. This particular study looked at basically the predictors of improvement with revascularization alone for ischemic MR. And reliable resolution of the MR was observed when there was at least 5 segments of hibernating viable myocardium. And this suggested that recovery of hibernating myocardium is crucial to restoring mitral valve function in ischemic MR. Now, the other interesting thing that this study showed was that the other marker was absence of significant papillary muscle dyssynchrony, i.e. more likely to respond to revascularization alone. More significant dyssynchrony, more than 60 seconds, which is really a marker of advanced disease, advanced cardiomyopathy, revascularization alone is unlikely to improve the synchrony, and MR therefore persists. And in this group of patients, we know these are the viable targets for cardiac resynchronization therapy, which we will discuss momentarily. So as I've demonstrated, pretty much every early study showed that uncorrected 2+ MR at the time of CABG was independently associated with increased risk. Now, is the MR a marker of advanced disease? Or does the MR independently contribute to the bad outcomes that was seen in these high-risk patients? Well, an RCT from the Cardiothoracic Surgery Network helped us answer this question. This is the CTSNet moderate ischemic MR trial. They randomized patients with moderate MR at the time of CABG to either receiving CABG alone compared to CABG plus repair with the undersized ring annuloplasty. There was 300 patients in the study, and the primary endpoint was LV remodeling, LVESV indexed. They showed that reverse remodeling did occur, but it did so equivalently between both groups. There was no difference in the primary outcome. There was similarly no difference in the clinical outcome, death, MACE, but CABG plus additional annuloplasty was a more durable treatment for the MR. Recurrence at 2 years was 11% in the combined group versus 32% in those that had CABG alone. And again, there was no difference in mortality, MACE, hospitalization, but there was a signal that was detected for higher incidence of neurological events in the combined group, which were mostly driven by TIA, as well as higher incidence of arrhythmia. So we then asked, we asked at this point, is lowering moderate MR at the time of revascularization from 30% to 11% worth the potential increased added risk of the procedure? These are the 2-year outcomes, and I think it's important. The long-term follow-up of these patients will be important to see if this additional MR translates into adverse clinical outcomes or heart failure. However, from the long-term follow-up of the observational series, again, in every study, we see that regardless if the treatment is just CABG alone or CABG plus annuloplasty, recurrence is associated with worse outcomes in both groups of patients. So the bottom line is with moderate ischemic MR, revascularization is likely and may be sufficient in most patients, but there may be select patients who will benefit from an additional annuloplasty anatomically. And what about for severe ischemic MR? So for severe ischemic MR, it's more agreed upon that it should be intervene at the time of CABG. And the severe ischemic MR trial similarly randomized 250 patients with severe ischemic MR to either a valve replacement at the time of CABG or a mitral valve repair with the same treatment, undersized restrictive annuloplasty. The primary outcome was the same, LV remodeling. And they show that there was no difference overall at 2 years in LV reverse remodeling in both groups. There was no difference similarly in death or MACE, but there wasn't a somewhat of an increased trend towards higher mortality at 30 days in the replacement group. Now, the striking thing was that MR was far more frequent after repair with an annuloplasty alone. And at 2 years, it recurred to moderate levels of MR in almost 60% of these patients, compared to only 3.8% of patients who had replacement. And this increased recurrence was associated with increased signal for heart failure-related events, as well as cardiovascular admissions, although these were mainly driven by ICD implantations. When you stratify these patients who had repair into those that had recurrence and those that didn't recur, so those that were still durable, what we see is that there's actually drastic levels of LV reverse remodeling in the good repairs, while the other groups didn't have significant amount of remodeling. And replacement really had the same amount of remodeling as repairs that had MR. So this suggested potentially that a good repair has LV enhancing properties over replacement. Now, just like we wouldn't, if we were a plumber, we wouldn't call this a repaired pipe. It's difficult as cardiac surgeons to call an undersized restrictive annuloplasty that recurs 60% of the time, a true repair in this setting. And despite the repair group containing 60% of failed repairs at 2 years, we see that there was no difference in symptom burden and heart failure hospitalization, although we started to see at 2 years an increased signal for heart failure events. And this suggested to many that potentially the LV enhancing effects of a good repair in this group were diluted by the 60% of those that had recurrence. And therefore even today, many surgeons still believe there's a role of repair in these patients, potentially involving other types, and they strive to identify why does repair fail in these groups. So it turns out while undersizing annuloplasty reduces AP annular dilatation, it does so at the expense of creating augmented posterior leaflet tethering, and as the annulus is drawn forward by the ring. And mechanistic studies, several of them illustrated this concept, demonstrating that geometric markers of PML tethering strongly would correlate with recurrence in ischemic MR. And since then, multiple predictors of recurrence have been shown, and really they fall into one of two groups, either markers of persistent or augmented tethering, as we see in these groups, or those patients that had ongoing amounts of LV remodeling. And particularly important one was the presence of inferior wall scar or dyskinesis or even aneurysm. And this was a strong predictor that was found for recurrence when patients had repair. And neither of these two factors are really addressed by undersizing annuloplasty. And this really drove home the point that ischemic MR is in fact a ventricular problem. So given the potential LV protective effect of a repair over a replacement and the clinical advantages that I outlined at the beginning, many surgeons still will advocate for other strategies of repair. So we turned to our own surgical experience over the last 15 years with a study that we performed with Dr. Fraser Rubens. We looked at patients that had treatment for ischemic MR with a mitral valve intervention at the time of surgical revascularization, and there are 337 patients. We were particularly focused on a particular repair technique, the edge-to-edge approximation, or what we call an Alfieri stitch, in combination with mild undersized annuloplasty band, and with the thought that these two factors would allow avoidance of this augmented leaflet tethering. Compared to valve replacement and traditional repair with undersized ring annuloplasty, we showed in the study that surgical edge-to-edge repair was associated with improved outcomes, but interestingly had a reduction in heart failure hospitalization, as well as they showed pretty good durability in the long term. And this would suggest that there's potential physiological benefit of edge-to-edge approximation in patients with heart failure. And of course, as we know, this is later corroborated by the literature in TEER and the benefits seen with that intervention, which we will speak about. So ischemic MR is a ventricular problem, as I said, but we've been since focused on the valve. Luckily, in the meantime, LV-enhancing medical therapies has drastically evolved over the last number of years to now what we have the 4 pillars of pharmacological management and HFrEF. And in addition to the benefits of these drugs in heart failure for mortality and symptoms, they have each been individually shown to reduce quantitative measures of MR. And this applies to both ARNIs as well as being currently investigated for SGLT2 inhibitors. All that's saying is, with the advent of good GDMT quadruple therapy, it's not unreasonable to be able to take severe MR and reduce it to 2+ or less. As I alluded to before, both ventricular and papillary muscle dyssynchrony can be mechanistic and worsen ischemic MR. Cardiac resynchronization therapy, of course, has been shown to acutely improve MR within minutes, and also has an effect in lowering the ERO over a number of months, and it's persistent over 3 months, as shown in these studies here. And really, these are the cornerstones of management in these patients. And then finally, TEER, or transcatheter edge-to-edge repair. As we know, it's based on the principle of the Alfieri stitch, where an edge-to-edge approximation of the 2 leaflets creates a double orifice valve, and this is achieved via percutaneous device. Everest's 2 trial initially demonstrated the safety of TEER and that it was effective in reducing severe MR down to levels of 2+ or less in most patients. We'll quickly review the 2 trials. So firstly, COAPT randomized patients with moderate to severe ischemic MR who were with HFrEF and persistent symptoms despite guideline-directed medical therapy. Importantly, their EFs were between 20 and 50%, and their LV-ESD was less than 70 millimeters. They randomized patients to guideline medical therapy alone or medical therapy plus MitraClip, and the primary endpoint was heart failure hospitalization. They showed in the trial that this technique was effective in reducing MR to levels of 2+ or less in pretty much 99% of people, and this had a prolonged effect over to 2 and 3 years. The primary outcome of heart failure hospitalization was reduced after TEER compared to medical therapy, as well as they found a mortality benefit when compared to medical therapy alone. Similarly, LV remodeling was seen with TEER. As you can see, almost immediately after the procedure, 1 month, you have a drop in LV volumes after the procedure. And by 1 year, this is equivalent to 3.7 mils. Over time, there's a progressive deterioration in the patients in this trial in LV remodeling. Although you can see this is clearly improved by TEER compared to medical therapy. And we see that this progression and deterioration in the LV is not worsened, it's not caused by worsened burden of MR, as the MR remains relatively stable even out to 2 years. MITRA FR similarly randomized patients to undergoing TEER compared to optimal medical therapy. Primary endpoint was death or heart failure hospitalization. And at 12 months, there was actually no significant difference in the primary outcome. So in this trial, there was really no benefit seen. So why did we see such different results across 2 trials for the same therapy? Well, this goes back to one of my initial points, that ischemic MR is heterogeneous. It is not just one entity. And just as in a Greek salad, for a given amount of cucumbers, you can vary the amount of tomato burden. FMR is very similar. For a given degree of LV remodeling, you can actually have a varying severity of MR. Patients in MITRA FR clearly had more dilated and sicker ventricles, whereas those in COAPT had smaller ventricles with a higher severity or a disproportionate amount of MR. And you can imagine if you were someone that only ate tomatoes, the group up here would likely get smaller. However, the other 2 bowls of salad would probably be less affected. And this was the concept that was seen across these 2 trials. Patients in COAPT had a disproportionately higher amount of MR, and therefore benefited from its reduction in TEER. And this is the hypothesis for one of the main differences across the trials. So this applies to patients on a day-to-day basis when being assessed anatomically for adequacy of or candidacy for MitraClip. And as we know, not all patients with secondary MR will be improved by TEER, and particularly the ones with more LV remodeling, dilated, sick end-stage ventricles with maybe less severity of MR. There were other differences across both trials with regards to the procedural success, with higher procedural success being achieved in COAPT, as well as differences in the medical therapy, and patients in MITRA FR had less optimized medical therapy at the initiation of the trial, and these were other 2 potential drivers of the difference in outcomes. So quickly, what do the guidelines say? Well, the only 2 class 1 recommendations are medical therapy, which is really key in patients with ischemic mitral regurgitation and heart failure. So good quadruple therapy and CRT for those that have indications. And they suggest early involvement of advanced heart failure for optimization of GDMT. For patients with persistent symptoms and who fall into COAPT-like anatomy, so EF between 20 and 50, less remodeled ventricles, and those without pulmonary hypertension, there's a 2A recommendation for TEER for a mortality benefit. And then for the surgical recommendations, patients who are undergoing surgical revascularization and have severe MR, it's a class 2A recommendation to intervene on the mitral valve at the time of surgery, and with a leaning towards recommending replacement over repair, given the durability in the long term. So returning back to our patient here, for this patient, what is the next best step? And it can sometimes be difficult, as I said, to consolidate all the evidence in the guidelines and deciding what exactly is the next best referral or intervention on this patient. I think the best way to organize really the management of patients with ischemic MR is by revascularization. Those that have indications for revascularization, those that don't. And I'll just go over just a proposed treatment algorithm for these patients. So those without indication for revascularization, primarily those that have symptoms on the basis of heart failure, medical therapy is the cornerstone for these patients, and consideration for CRT. And once these are done, reassessment of the symptoms, is performed. If these patients have persistent symptoms despite GDMT, then they can be considered for TEER if they have favorable anatomy. And for those that don't, and maybe who aren't candidates for this procedure, there are other options that are maybe investigational TMVR, and of course, kind of, down the line, of course, mitral valve replacement, should these patients be very symptomatic. But at this point, we should be considering, are they a candidate for advanced heart failure therapies, such as a transplant or a VAD. Now, those patients with indications for revascularization, angina or high-risk anatomy, the cornerstone here is really revascularization. And based on the anatomy, they should undergo probably PCI or CABG. Those who undergo PCI and still have MR, likely TEER will have a role for these patients. Now, those that undergo CABG, as we said, moderate MR, in many cases, revascularization will be sufficient to treat the MR, and for select patients who can add a repair. However, the trickiest group, I think, in this algorithm are those with severe ischemic MR and indications for CABG or surgical CAD. The guidelines would say at this point to do a combined procedure of both CABG and MVR, but we know that these are high-risk surgical candidates, and mitral valve surgery further increases their risk. So is there a potential role or benefit for TEER as well in this population? Should we be avoiding surgery completely in this high-risk group? So while there's no direct evidence, comparing these two treatment groups, we have to ask ourselves right now, do these patients still have an indication for surgery anymore? Or can they be, can we achieve the same treatment completely percutaneously with avoiding sternotomy? We must remember that patients with ischemic cardiomyopathy have a class 1 indication for surgical revascularization, and this is for mortality benefit, as I demonstrated near the beginning. Conversely, in the recently presented trial at the ESC, the revived BCS2 trial, they showed that PCI in ischemic cardiomyopathy doesn't offer the same prognostic benefits or improvement in the cardiomyopathy. So I think it may be reasonable to say that there's still a role for surgical revascularization in these patients. Now, that said, we should consider, does the long-term prognostic benefit of surgical revascularization outweigh the upfront morbidity with a combined procedure? And this is something that should be assessed on the patient-to-patient level. If the balance is not favorable, I think TEER is a wonderful option in these patients. And a potential treatment target may be the use of TEER to spare the need for mitral valve intervention at the time of revascularization, potentially reducing surgical risk. And this is an interesting strategy. However, it is yet to be validated and studied in this patient population of surgical candidates with indications for CABG. And then lastly, and furthermore, the long-term durability of TEER is still not known, and this will become more and more important as patients with ischemic cardiomyopathy have better prognosis with medical therapy. So these questions clearly remain to be answered and are going to be areas of active investigation in the future. But therefore, at least for now, we will stress the importance of surgical revascularization in these patients for those who are candidates, and continue to learn and explore about the expanding role of TEER. So just to wrap it up, in conclusion, ischemic MR is a complex, heterogeneous group of patients with elevated risk, pretty much across all the whole cardiovascular realm. For those that have indications for revascularization and high-grade anatomy, surgery is indicated for improvement in LV remodeling and prognosis. Medical therapy is cornerstone and is king in these patients. Good guideline-directed medical therapy and resynchronization therapy can improve the MR probably in most cases. Those that have persistent symptoms after this is done can be considered for TEER if they have significant amounts of MR and co-op-like anatomy. And then finally, TEER, as we know, will have an expanding role in this patient population, and we continue to learn about its role more and more. I want to thank everyone for listening today. I'd be happy to take any questions.
Thank you very much, Nick, for that overview. That's definitely a very complicated patient population to manage.